Hi, I'm Savannah, and today I will be going over health behavior disparities of alcohol use among Native Americans with my other presenters, Cynthia, Ashley, and Juan. So first, I'm going to be overviewing alcohol use. And alcohol use is a health behavior, and it can be defined as the consumption and ingestion of ethanol, and ethanol is the only type of alcohol that is able to be ingested by humans. It is also important to note that approximately 20% of Americans are consuming more alcohol than the suggested guidelines. Native Americans also have the highest prevalence of heavy drinking, 12.1%, along with the highest prevalence of binge drinking, 29.6%. Native Americans of both genders also have the highest prevalence of weekly heavy drinking, 21.63% and 22.19%. And early onset of alcohol consumption earlier than age 15 is highest among Native Americans at 16.43%, compared to the next highest group, Hispanics. And the Hispanic rate of early onset alcohol consumption is at 7.93%. Lifetime alcohol dependence is prevalent in 12.5% of US adult population, and Native Americans have greater odds than whites for alcohol dependence. Next, I'll be talking about the outcomes of alcohol use and the biological and social outcomes. So the biological outcomes are affecting your brain, and it disrupts the brain's communication pathway. It also affects your heart, and you can have cardiomyopathy, arrhythmia, stroke, and high blood pressure, along with affecting your liver. You can have a fatty liver or fibrosis, and it weakens your immune system, and you also have increased risk of cancers. And some of the most prevalent cancers that are related to alcohol use are esophageal cancer, liver cancer, and breast cancer. The social outcomes of alcohol use are it's the third leading cause of death in the US with 88,000 deaths per year. And advertisements are targeting racial minorities and younger drinkers. On the left, I also have an MRI scan of the effects of heavy drinking on a teen brain. And on the left side, there's a 15-year-old non-drinker compared to the right side with a 15-year-old heavy drinker. And you can see the lack of neural firing in the right. Next, I will be discussing the health inequity of alcohol use. And the study I'll be going over is the substance use among American Indian youth on reservations compared with a national sample of US adolescents. And the goals and findings of this study are American Indian youth attending school on or near reservations are historically at high risk for substance use, whether that's marijuana or alcohol, along with other illicit drugs. And participants in this study were 578, 582 10th, and 508 12th grade students. And the findings from the study indicate that compared to the students off reservations, American Indian students reported substantially higher lifetime and last 30-day substance use rates. And the relative risk ratio indicated that 8th grade students had a 2.1 relative risk for alcohol use, and relative risk ratios have a baseline of 1, and anything greater than that suggests an increased risk of the outcome, which in this case was alcohol use or other substance use. And for the study, it found that alcohol use along with marijuana use was the highest.
Hi everyone, my name is Cynthia. The theoretical framework that relates most to our project is the Myers model of disparities. Myers framework is an associative theoretical framework to understand how racism, poverty, alcoholism, and other stressors can affect our health through psychological and biobehavioral pathways. The man on the left is Hector F. Myers. He created the model. Myers has a PhD in clinical psychology from UCLA, and he has spent more than 39 years as a professor in clinical and health psychology. He specializes in clinical and health psychology, ethnic disparities in chronic diseases and mental health, HIV and AIDS, and health promotion and risk reduction interventions. Next slide, please. On the left is Myers' model. By looking at the model, you can see the complex relationships between the races and ethnicity. The model interacts over time to predict the health outcomes of the psychological adversities and cognitive emotions, behavioral and biological pathways. This leads to the development to predict the health status of a minority. The minority groups are going to continue to have declining health and quality of life while health cost increases. The overall health status will decline for minorities. What are the implications? The implications are minorities already have a hard time, but the declining health going around will only worsen. While improvements have been shown, there are substantial ethnic differences in the relative risk of congenital heart disease. And then the weakness and limitation is the worsening of the health isn't everywhere in the United States, but it is in the recent decades, health has been improving for Caucasian and Asian communities, while it is difficult to pin out all health disparities in all ethnic groups.
Hi, my name is Ashley. I'm going to talk about a study that reflects biopsychosocial model, focusing on the psychosocial. So Whitbeck et al. Did a study to investigate the effects of perceived discrimination, historical loss, and enculturation on alcohol abuse among American Indians. The study was comprised of 452 parents from 2 upper Midwest and 1 Canadian reservation. Enculturation was described as the degree to which someone is embedded in their traditional cultural practices and cultural identity. This was assessed by asking the participants about their participation in traditional activities, identification with the American Indian culture, and their level of traditional spirituality. Historical loss referred to the cultural genocide, ethnic cleansing, and forced acculturation that has been experienced by Native people in the US that have resulted in historical and intergenerational trauma and unresolved grief. This was measured by asking the participants about their level of historical loss. They perceived using a scale that addresses loss of land, language, culture, and spiritual ways. Other losses that were measured was loss of family, loss of self-respect, loss of trust, loss of people through death, loss of children's respect for elders and traditional ways. Symptoms of historical loss were also measured with a scale that assessed things like anxiety, depression, shame, avoidance of people, feelings of discomfort around white people. Perceived discrimination was measured by asking how often they had been insulted, treated disrespectfully, hassled by police, ignored, been a recipient of racial slur, threatened with physical harm, suspected of doing something wrong, treated unfairly, expected not to do well by white people, discouraged to achieve an important goal, and treated unfairly in courts as a consequence of their American Indian minority status. Finally, participants were given a diagnostic interview to see if they met the criteria for a 12-month diagnosis of alcohol abuse according to the DSM-3 criteria. So results showed that 75% of the adults met the criteria for lifetime alcohol abuse, and of these people, 15% met the 12-month criteria for alcohol abuse. Among those that met the 12-month criteria, alcohol abuse was also negatively correlated to measures of enculturation and positively associated with historical loss. It was also found that perceived discrimination was also positively associated with enculturation, historical loss, and alcohol abuse. In other words, those with low levels of enculturation and higher levels of perceived discrimination and historical loss were more likely to abuse alcohol. Enculturation was also found to not significantly buffer the effects of perceived discrimination on alcohol abuse. The study suggests that because discrimination and historical loss are strongly associated, discrimination experience might act as a reminder to Native people of the historical loss associated with the policies of ethnic cleansing and forced acculturation. The results also suggest that enculturation could be a protective factor against meeting the 12-month criteria for alcohol abuse, but this is limited because it apparently does not protect against the effects of discrimination on alcohol abuse. It's also interesting that those who reported being highly enculturated in their native culture were more likely to experience historical loss. So deep enculturation can be protective, yet it also seems to sensitize them to historical loss, which is strongly associated with alcohol abuse. Because historical loss is associated with alcohol abuse, it could be that alcohol is used as a coping mechanism to reduce or numb the thoughts and feelings of historical loss, or it could be used as a self-destructive behavior in response to anger. Or it could be the other way around. Alcohol could have effects on perceived discrimination and historical loss. It's also important to note that there could also be another variable that has an effect that wasn't involved in the study. The study was done on a few reservations, so it might not be representative of all Native people, as cultures differ between tribes across the country. Now, to apply the Myers model to explain the findings by Whitbeck et al., we see that race, ethnicity, and socioeconomic status interact over the lifetime that affect psychosocial adversities. So in this study, the fact that Native Americans are a minority and many were of lower SES, the study said about half were on some sort of federal financial assistance, and some single parents even made less than $15,000 a year. So that can interact and have an effect on their lives and experiences. So we can see how these factors can act as stressors and interact to affect how the Native Americans experience adversities. That in this study included stress from perceived discrimination. The discrimination experience, as the author suggested, might then be a reminder of the historical loss of a Native people, which has an effect on cognitions and emotions. This greater vulnerability to negative cognitions and emotions can lead to a reduction in individual reserve capacity. And this was seen in the study as well, when the higher levels of enculturation was somewhat protective, but not when perceived discrimination was high. There's also many historical effects that contribute toward alcohol use in Native Americans. According to an article by Bovas in 1998, Introduction of Alcohol to Tribes when European colonists first came to Americas, and the social modeling of drinking that is passed down through generations. He also talked about how many Native children were forced into boarding schools to be forced into acculturated or forced to acculturate to Western European culture, where they endured a lot of trauma. These social effects might be a contributing factor to why Native Americans not only tend to drink more alcohol, but also begin drinking heavily in adolescence earlier than other races. All these accumulated effects makes this population more predisposed to engage in risky behaviors, such as alcohol abuse, which can lead to higher likelihood of alcohol-related health problems, such as liver disease. This explains why, as cited by Whitbeck et al., alcohol abuse is a big contributing factor to preventable deaths that are 133% higher among Native Americans than of white people of the same age.
Okay, so now we're going to talk about the interventions and the physiological aspects that alcohol has in our bodies. So basically, alcohol acts as an inhibitor, mimicking GABA, which is a neurotransmitter, a main inhibitory neurotransmitter in our body. And specifically, ethanol in alcohol tends to bind to GABA and glutamate receptors, according to Zhao, Zhen, and Peoples 2016. Okay, so GABA versus NMDA receptors. So as I stated, GABA is the inhibitory neurotransmitter present in our bodies, and NMDA receptors is an excitatory neurotransmitter receptor that is present. And alcoholics have reduced GABA receptors because alcohol is an inhibitor itself. And they have increased glutamate receptors to try to balance out the high inhibitory chemicals that alcohol introduces to our bodies. So according to Jesse et al. 2017, due to the increased glutamate receptors, stopping from drinking alcohol, specifically in alcoholics, can lead to seizures because of that high dosage of glutamate that is present in our bodies, because of that homeostasis balance that our body tries to fix because of the inhibitory chemicals that is presented with alcohol. Okay, so now we're going to talk about the excessive presence of glutamate in our bodies. So another study by During and Spencer in 1993 stated that significant increases in glutamate in our brains leads to neuronal activity that is very much similar to epileptic patients. So as I stated earlier, the high presence of glutamate is because our body's trying to balance out the GABA that is presented with the drinking of alcohol. So basically our bodies really produce a lot more glutamate to balance that out. And if we just take away the alcohol completely, that will leave glutamate highly present in our bodies without the counterbalance of GABA that was balancing it out because of that alcohol. So according to this study, the high dosage of glutamate is what can lead to these seizures if we just remove the alcohol away completely. Okay, so instead of completely taking away the alcohol, the proper intervention would be to slowly taper off of GABA, and not necessarily by drinking less alcohol, because that would kind of be counterproductive. But instead, we would taper off of GABA by introducing our bodies to some drugs called benzodiazepines. And benzodiazepines are high in GABA. So basically, we would slowly taper off of GABA. We would slowly taper off of GABA by taking these medications, but slowly reducing the dosage of the medication so that we don't shock our bodies by reducing the GABA neurotransmitter completely, like we would if we just reduced the alcohol completely. Okay, so let's talk about seizures and benzodiazepines. So another study by Jesse et al. 2017 stated that within the first 2 days, these drugs called benzodiazepines reduced the likelihood of seizures by up to 84%. And after the third day, these drugs can slowly start being reduced so that eventually we can taper them off completely. So that, again, as I stated, we don't shock our bodies by reducing the presence of GABA in our bodies. Okay, and lastly, we're going to talk about social support. And this is another big aspect of interventions that we can take besides the physiological aspects that we can do. So another study by Booth et al. In 1992 stated that the social support from friends and family greatly lengthens and eliminates the possibility of entering into relapse. And then again, on the other hand, according to Booth et al., the lack of social support from friends and family can significantly increase the chances of re-entering into relapse and falling into the addiction of alcohol once again. So the use of benzodiazepines to reduce GABA slowly and the presence of social support are both greatly needed as interventions to taper off of alcohol slowly.
And here are our references. Thank you for watching.